Michael, and thank you, Tecnalia, for inviting me for this talk. So I'll start with the talk, first presenting, as you mentioned, Osakidetza is the Basque Health Public Service, and within Osakidetza, who is the core of also for the research, in the ecosystem we have 4 health research institutes, and I'm coming from one of them. Just to put you a bit on the scope, what is a health research institute? So there is a certification related to the Spanish government and the Instituto Carlos III, which the objective of health research institutes, not only those that are in the Basque Country, but that are at least overall in Spain, is to bring basic clinical and health research, health services research closer and translated for excellence. So usually this is configured, we are configured, for example, Biogipuzkoa or other health research institute, around a university hospital, primary care area of this, in combination with a rich ecosystem of research centers and universities. In our case, we are located in the Gipuzkoa region of or province of the Basque Country. And in the figure, we can see somehow how this is distributed in different trusts. And as I mentioned, our goal and our vision or our work is to, based on identify clinical needs, and also our work is on identifying these clinical needs, perform basic research, clinical research, and research in health services, so that this can be translated to citizens and patients. So our research group includes diverse people from basic research, preclinical research, also from research centers and also from universities. Okay, so one of the points of my talk is we have had really nice regulation talks. So I focused a bit on why this implementation is hard. So regulation told us how to act, but then we have to move to, let's say, to real world and real problems and have to try to solve them. So I'm going to try to report what I have experienced both in Biogipuzkoa and also on my previous background, the experience of projects, not going specifically to a certain project like for Compass, but kind of wrapping up what has happened or seen. I mean, I've been in working on EU collaboration projects within Biogipuzkoa, also care system research or multi-clinical sites without only clinical institutions. And from my thoughts, the barriers that I have somehow identified why AI solutions are not working, first of all, have to underline the need to involve people and processes and involve people on those processes. First of all, identifying clinical needs. Many times solutions are technology triggered and not patient or clinical needs triggered. Many times these stakeholders are involved in a late state and the workflows of development are misaligned. Also, many times governance and regulation makes this responsible, but also in many cases, as also Inigo has introduced, there are different and divergent national rules, which EHDS somehow tries to solve. Many times the access procedures are complex and they have to be in order to guarantee the data protection, and also the data protection can be something complex. And also related I think this is also an issue related to data and infrastructure, the heterogeneity of data sets, interoperability among them, and the fragmented. So many times the real challenge is not building AI models, it's rather creating ecosystems for this multi-stakeholder collaboration and the conditions so that they can be responsibly developed. Okay. So if we go to real projects, I have worked with different technical solutions. I have tried to show some. I mean, in some cases, data is shared within the same organization or with trusted partners. Depends also on the agreements and the relationship you have. Many times this goes towards restricted workspaces, somehow like secure processing environments that EHDS is proposing, like virtual environments or secure analysis sandboxes with layered controls. In experience, or I have experienced that in some cases these are required to be on premises, depends on the policies of institutions. It could be on private, not public, private cloud instances or centralized research platforms. For example, for retrospective data analysis or so, many times these are somehow on-premise exercises, while maybe as in Compass, when new cohorts are being captured and so on, based on joint controller agreements and informed consents and so on, this can be stored within a centralized research platform, like the one that was presented in Compass. Many times these have layered controls. Most of the times I've worked with VPN and two-factor authentications to be able to access, despite I've seen some cases with, maybe I'm getting a bit technical, but it's SSH with public-private key sharing. Related to agreement models of access, I've experienced both at institutional level and also institutional plus individual level commitment. And related to federated analysis, many of us, at least those that are technical, surely have research with federated learning and these kind of approaches. In my case, the most things that I've seen are simulated federated learning, data sets which are hosted within the same data space that you do for some research. And in the case that is real federated learning, is usually with really specific, restricted, limited data sets and network configurations. And most of the times, for many of the users are federated analysis that maybe is the script that is sent to certain places, like if there is a OMOP interoperable common data model mapped data set, that then maybe you run the same query in different places. I don't know. Okay. Current data access reality. I'm not showing the one from Osakidetza. I think this is a general experience from different data holders in the current state, which usually undergoes through an ethical committee, which checks the research protocol, and after iterations, you might get an approval. A DPIA, some of them with specific templates for AI, how the AI is being developed, and many times this is maybe checked with a data protection officer, which then leads to an institutional auth. I have placed institutional auth and data access committee separately, but many times these are jointly run. I mean, I've seen institutions that have separate entities and some that have joined of them, but at the end, what's on the back is that there is an organizational sign-off related to strategic alignment or required resource availability to prepare these data sets and so on, because this involves people and services, paying services. I've talked about institutional, but you can also consider institution if you set up a institution for Compass exploitation later on. So this can be also considered. And data access committee, what I have written as is that depending on the request that is made, the the analysis and the assessment of the dataset privacy level that is being requested, because the cohort could have lots of variables and lots of possible aggregations. And as I have underlined below, we are seeing also that increasingly institutions are asking recipients safeguards, so that if data is to be shared, I somehow will trust more on somebody that has an ISO 27001 certification if they show me some internal governance procedures, incident response capabilities, and so on. So if I'm able to share it, so I would say that there is a quite diverse context, I would say, of sharing the data, where you can have more or less trust and so on. Okay, so Inigo has nicely introduced already the incoming parallel route. He has already told that this is not a pathway that comes to substitute, but it's a complementary one. We will keep on existing, I called it institutional layer, but it would be GDPR-based approach. So we will have, as I commented, like ethical approvals, DPIA, local authorization, consent where it's required, and the new EHDS route, where, as he introduced, the participation will be mandatory for data health and health-related data holders. We will have national access bodies, harmonized EU procedures, no consent required, and access will be restricted to secure processing environment. At this point, I will present two more approaches that I have experienced. One of them is raised, but there are other alternative implementations which are related to data visiting, where the data owner or data holder activates a race or a system of the local system, and data becomes accessible from the system. Researcher is shared with a shareable version, could be a synthetic version or anonymized version. Researchers works with this data set on their local machine, and they develop scripts or AI training system, and then this is sent to the node that has the data set, which runs and registers the results. And this is the results, and the experiment is written in blockchain, and it's provided at DOI. So the benefits of these kind of approaches are that the institution can retain the full control of sensitive records, that different data owners can have different nodes and distributed analysis, reduce of data transfer risks, and that the patient privacy is preserved at source. I also would like to mention the European Genome Phenome Archive, EGA, where this ecosystem allows the storage of genotype and phenotype data. And they are somehow a data processor, so whoever owns the data, whenever uploads this data to the EGA, prepares somehow a data access committee rules, how you will rule your system, and prepares the data processing agreement, which will be offered to those that ask for that data. So EGA is somehow a broker with a catalog where you can find different data sets that are uploaded, and whenever somebody requests access to that data, this is passed to those that are the data owners, and based on the rules, they decide whether they allow to share or not, based on if they ask for further safeguards on the recipient or whatever. So these data committees review every request individually. Permissions are granted only for a specific, and you can maybe shape your data processing agreement based on the needs. And this model, for example, for the Instituto Carlos III calls, which is a Spanish ministry call, Ministry of Science, it's one of the recommended model for supporting open science. So if you get granted one of their projects, you have to deposit it's one of the repositories recommended for genomic data. So, I mean, it's not open access, it's controlled access. Okay, just a short recap of this alternative. We have seen the data visiting approach, the controlled data access with per data holder data access committees. So my thought or insight on this was that there will be no single model. I mean, we have heard that the HDS is coming with SPEs and so on, but future models must be interoperable with diverse architectures, both institutional access, federated analysis, repositories, and secure environments, which I guess that we will see on later years. A small stop related, looking a bit forward on privacy and risk in technologies. I have called it promises and open questions. We have, at least those that have a technical background, have heard about federated learning, synthetic data, morphic encryption, or differential privacy. From my experience, they look really nice for research, and they seem, or I think that they will in the future get implemented, and they will facilitate. I mean, like federated learning only passes models, weights, and not data, which can enable certain, theoretically, can enable certain private and nice scenarios. Synthetic data, which you generate new data, completely new data based on the statistics that you have learned from data, also could be a really nice option, or differential privacy, and sometimes some of these are combined in some projects. But what I have also mentioned is that the overlooked challenge, which is the selection of appropriate metrics and thresholds before sharing or implementing these technologies. For me, it would be key determining the acceptable rate identification risk levels, so this can be adopted. Okay, moving a step forward. Some of this info has been already introduced by Inigo, so I will try to go quick. So, as he mentioned, data that will be personal, will contain personal data, will be only available in a secure processing environment in the EHDS. Data will never leave the controlled environments. One of the things or points that I would like to underline is that SPs will have different functions and capabilities. The specifications are being worked like in TEDAS2 project and so on. But as we will clearly see that if you want to develop trustworthy AI and have a track of data sets and models and so on, you will also need certain capabilities in those environments that you will enter to work. In some, you might need a GPU, some you will only have enough with CPUs, or whatever. So beyond the pure SP specification, then we will see different providers and different options. And it was also mentioned by Inigo, the infrastructure cost of maintaining these SPs and so on, despite that you can charge some to the data users as he requests, but there are some overall maintenance stuff, operational complexity, that this will require audit trails and so on. And one of the points that I was aiming to focus was on the export restriction. There will be a small or a big problem depending on how we tackle it, which is how we export the results from those environments, which somehow can limit downstream innovation. So there are projects working on this. And one of the projects working on this, I'm not working on this, I would like to, but I'm not working on this project. It's the Shaped project. It's one of the key EHDS related projects, so it's one of those to keep an eye on it. And their mission is to create a secure, efficient, regulation compliant AI as medical development, especially in the EHDS ecosystem, I would say. So they are working on enabling HDApps for AI development, aligning them with different regulation, developing tools for them, and also they have some use cases so they can validate them. And in the discussions with a colleague which was working here, he also told me that they are looking at different options, which one could be those models that have been trained in secure environments, somehow maybe exposing them through APIs or somehow related, which will also make some new risk will arise, which would be like security testing or checking those continuous anomalies. So this is a bit looking, and I would keep an eye for those interested on the deliverables that will come up. Because as I said, maybe exporting results or exporting models is hard, but I would say that what they are trying to aim, like certifying that your software algorithm which is developed with certain data within an SPE, it's even harder. So, but people is working on it. Okay, for data holders, readiness is not optional. As Inigo mentioned, joining this kind of ecosystems requires defining the IPs, the access condition and licensing policies for Compass data, for example, assessing the data maturity and quality. I guess you already have done, which is engaging with clinicians who understand EHR data capture decisions. Many times things that are on the EHR are depending on different policies or how this was captured at some time, but after this year, this has changed and this is now captured in some other way. This happens. And ensuring the correct labeling of quality. So in this ecosystem, people is able to identify data that meets and fits their needs. Okay, so this again a wrap up of data quality and collaboration that AI trash in, trash out, that the AI reliability depends on data readiness, that solutions have to be built upon a rich ecosystem, and we think clinicians, data engineers, and those domain experts that might know about decisions of how this data was written, and that this is an economic and human effort if we want things to make work. I wrote 2 projects to keep an eye on the results. One of them is, I don't know the name, I tried to find the name, which is an IHI called Topic 2. I'm aware that the project was granted already. And the topic was enabling and safeguarding innovation in secondary use of health data in EHDS. IP management in, this is what I have had. IP management in the EHDS secondary use. They are, at least the call was asking for how on the EHDS regulation, it is said, as Inigo said, that data holder can declare the IPRs of their datasets, but who makes the decision on how, if you are obliged to share or on which condition is the HDAP. So this project is looking at the contract or how this should work. So I think it's a project to keep an eye on. And the second one, which was already mentioned also by Inigo, is the quantum project. It's not about quantum technology, but it's about the quality of data on EHDS. And is the one that is defining the quality levels for EHDS collected data sets. It's compulsory by the regulation for those data sets that have been captured using public funding. It's not mandatory for those that are not. Correct me if I'm wrong. And they are also providing means for data holder maturity assessment. So you can know who is saying my data has this quality more or less on, and you can improve your maturity. Okay, I think I'm talking a bit much, but let's continue. Okay, just a few words about trustworthy AI. I'm not an expert on trustworthy AI, but from what I have experienced, first of all, the core is I would say the data quality, which needs a rigorous data curation, validation, and quality assessment. So I have written here the data curation and quality assessment, the traceability of the operations that we perform over it, and whenever we prepare certain AI, the strict separation of trained test data. From my experience, from early times, when I was working with AI, at the beginning everyone was looking at predictive performance and getting the best metrics of accuracy. There was certain maturation, related to data set and model versioning and full traceability for reproducibility means. Within, I would say, adoption, looking more for adoption was the testing across different health systems in order to see that something that has been trained for a certain population works for others. And finally, now within this era of, as we have seen with Guillermo, of AI Act and NDR or IVDR, we see all this together and the documentation and keeping the track of everything that is done so that we can rely and trust on those experiments. Well, I have written here now 5 dimensions of trustworthy AI. There were some others shown. As big data, Bs for big data, we can have as many as we want. Just shortly looking at the fairness and the lack of bias, the robustness related to the adversarial attacks and distributional shift that the AI works as it should. The explainability on knowing the reasoning, or providing the reasoning to clinicians and patients why certain decision is taken. And the safety related to liability and having humans on the agency and oversight, and accountability and monitoring of how the system is working in environments as new data arrives. Just a few pointers to some interesting projects. This is one, and there are different networks of excellence that are funded by the European Commission. Maybe many of you are aware, but I have placed a link there where different networks of excellence are named. Some are specifically focusing on trustworthy AI. And I think that they are quite interesting to look their roadmaps and so on, so to see what technologies are developing. I'm currently, I've been reviewing this project, the ELSA project for the Commission, and they are more focused on secure and safe AI, and they are not focused on some other dimensions of it, but they have done, or they are doing cutting-edge technology on adversarial attacks, on developing libraries so you can use them within your ML to avoid this kind of attacks. And they are proposing different explainability approach that are built into the models when you are building them, and different human-in-the-loop approaches. As an example of one of the methodologies they are proposing is ML Trust Ops, which is trustworthy AI ML operations. They have more details, but is that also considering certain aspects of trustworthy AI within the development and deployment of loop of this. I have 2 slides left. Be quick. One stop on adoption, which will require all the regulation that was mentioned previously also by Guillermo. Even when they are technically and valid and functional, there are some other steps that are required. Health technology assessment, which can also be started from the beginning. which is whether, besides what has been regulated and promised, how well it fits and how into the current adopter and the costs, that if it's cost-worthy, let's say, for the need that is there. The local performance validation, the workflow integration within the EHR system, and so on, and the procurement and deployment. I'm not an expert of this, but it was also kind of making a message, or providing a message from research to also to adoption, that there are some other tasks that need to be performed. And that's all. So thank you very much.